Welcome. Today I have a very special guest with me. I have Dr. Mohit Khera, who is a professor of urology at Baylor College of Medicine. He also holds the F. Brantley Scott Chair in Urology. Dr. Khera specializes in male and female sexual dysfunction, men's health, and hormone replacement therapy. He also serves as the director of the Laboratory for Andrology Research, the medical director of the Baylor Executive Health Program, and the medical director of the Scott Department of Urology. And in his spare time, he acts as president of the Sexual Medicine Society of North America. Welcome, Dr. Khera.
Thank you, Karen. Thank you for having me on the show.
This is great because I have traditionally talked a lot about female sexuality and female issues, amongst other things, and I'm very excited to address the male audience that I have having you here today. Although I know you work with both, you seem to have a different approach to it, so that's why I'm particularly happy that I got to speak to you first in this arena. So, what brought you into men's sexual health?
Yeah, so I'm a urologist by training. I finished my urology residency, and after I finished, I wanted to super specialize in sexual dysfunction. So, sexual dysfunction is an area of field where you're actually improving someone's quality of life. And so I also realize that many men who suffer from sexual dysfunction suffer in silence. They don't talk about it. There's several studies that show they don't even talk about it, not only to their physicians, but up to 44% don't even talk to about their partners. They just avoid sex. And so it's very actually quite sad. These men just live with the condition. And I thought to myself that this is probably one of the best fields you can go into if you can build awareness and if you can offer them treatment.
What I found really interesting when looking through your work and reading more about it is that a lot of the issues that women face, men face, but we just make this assumption that men have this great ego and, they're not really talking about it, or they're talking about it in the locker room. But in fact, it sounds like the shame that we have is very similar to what men are suffering from.
Very similar. And remember, not only in women, but also in men, it's a very high prevalence. The numbers I tell the residents to always remember is I say, look, 40% of men at 40 have erectile dysfunction. 40% of men at 40, 50% at 50, 60% at 60, 77, 100 at 100. You live long enough, a man's going to get erectile dysfunction. So these men come into my office and they say, how could this be happening to me? I said, Mr. Smith, you're 65 years old. If it's happening to you now, you beat the odds, right? So now it's happening. But the good news is that there's things we can do to fight back and improve the sexual function. Now, we'll get into this, but historically, what we've done is we've always been reactive. Reactive means we wait till you get erectile dysfunction, then we start a pill. And if the pill doesn't work, we start an injection, then we start something else. And I think this whole paradigm is shifting to be proactive. And how do we be proactive? It's diet, exercise, sleep, and stress reduction. Those are the four pillars: diet, exercise, sleep, stress reduction. Not only does that help reverse erectile dysfunction, not only does it help prevent erectile dysfunction, but think about all the other medical conditions I'm treating: diabetes, hypertension, metabolic syndrome. So I really believe that, this proactive approach really is the way to think about treating ED and preventing ED.
So talk to me about that a little bit, because as I understand it, erectile dysfunction can be a sign of other diseases, not just sexual dysfunction.
Great point. So this is where people start getting their attention. If a man develops erectile dysfunction today, 15% of them will have a cardiovascular event within 7 years. That's a lot, 15%. So the reason behind that, and many people have shown that ED is the first sign of a heart attack. Why is that so? Now, there's several theories. One of the theories is called the arterial diameter theory, which means, if you think about it, the penile arteries are only 1 to 2 millimeters. The coronary arteries are a little bit bigger. They're 3 to 4 millimeters. The carotids are typically 6 millimeters. If you are going to occlude an artery in the body, you're more likely to occlude the penile artery first before the coronary, more likely to occlude the coronary before the carotid. So it is true, men will get a ED before they get a heart attack before they get a stroke. It follows that stepwise fashion. So if a patient comes into my office and they have ED and they have 2 cardiac risk factors, maybe they're a smoker, maybe they're obese, and they've never had a cardiac workup, we send them. And the risk of finding a cardiovascular disease is about 30%. So think about it. I mean, this is really one of the first signs. There have been other studies. There was a wonderful study that came out of St. Louis looking at database, looking at diabetes, and looking at erectile dysfunction. If a man, these are young men between the ages of 18 and 45, they were young. If a man developed ED and was going to get diabetes, 75% of them were diagnosed within the first year. So you can use as a marker for diagnosing diabetes and ED. And the last one is, what about depression? You can't discount the fact that men who get ED suffer from depression and anxiety significantly. And realize that anxiety and depression, if you treat the ED, you can actually improve the anxiety and depression. So there are many things that are associated. I said that sexual dysfunction correlates with mental health and physical health. And by treating your sexual dysfunction, you can actually improve mental health and physical health as well. So it's all correlated.
Right. Dr. Kelly Casperson talks about the biopsychosocial effects. Everything is all intertwined.
I want to mention something very important. Think about this. If a guy comes into my office and he says to me, he has hypertension, let's say hypertension, and I say to him, I want you to eat healthier. I want you to exercise 2.5 hours a week. I need you to sleep 7 hours a day, and I need you to decrease your stress. And if you do that, your hypertension will be better. A lot of times they say, just give me the pill. You know, if I tell a guy, you come in, he has erectile dysfunction, and I say, I want you to eat healthy. I want you to exercise. I want you to sleep better. He will do it. So it's almost like ED is the gateway to getting men to change their behavior. And by the way, the hypertension will improve and the diabetes improve, but ED is really the impetus to get them to change their behavior. And they do it. I mean, they really make an effort to stick to the program.
What are some other causes of ED, though, if it's not related?
Right. The mnemonic I teach the residents and the medical students is VENT: vascular, endocrine, neurologic, and trauma. Vascular is the most common cause of ED in the world. And there's two types of vascular. It's very simple when you think about an erection. Blood has to come in and blood should not come out. So if the blood comes in and it doesn't come out, it's going to cause an erection. But let's say the blood comes in, but the blood comes out faster, then you're not going to get an erection. And that's the most common cause of ED, called venous leak, meaning blood comes in, but it's coming out too fast. And what will the patient tell you? He'll say, I can get the erection, I just can't maintain it. He's telling you he's got venous leak, right? So I can get the erection, but I just can't maintain it. Right. So vascular is the most common cause of ED. Now, the other things you cannot forget are medications. They're notorious. Beta blockers. You know, I mean, we take them for blood pressure. I mean, there's many medications. SSRIs, antidepressants can cause it as well. And then don't forget, a large percentage of sexual dysfunction is psychologic, right? So it's your partner, it's the stress, things that are going on in your mind. And many times I'll say, a man will come to me and say, I have ED, but no problems with masturbation. Well, then it's psychogenic, right? I have ED with my wife, but one of my girlfriend, I'm not, so that's psychogenic, right? So we have to question whether this is psychogenic or not.
Interestingly, these are very similar causes of females' libido issues. So it's right. Almost the same answer for both, even though the treatments are different. It's funny because a lot of men that I meet, I don't think they realize that. I mean, I have friends who share their Viagra, and what you're really bringing to my attention is that don't do that, because there could be something serious going on here, and it's not just that you can't get hard.
Exactly. If you absolutely could be the first sign of a more serious medical condition, right? And that's very important to get it evaluated.
One of the things I love about when you speak and your method of treating, you talk about treating in the case of, I'm assuming heterosexual couples, but I imagine this is true in any relationship between two people where ED is an issue. Talk about your more holistic approach.
Yes. Well. So we have to talk about this in the context of a story. So in 2008, when I finished my fellowship in 2007, and I specialized predominantly in male sexual dysfunction. And I was so proud of myself. I was able to get these men these amazing erections, great libido, and then they would go home and they'd have no one to have sex with, right? Because the wives would come in, or the partners would come in and say, look, things were great until he met you. And now we fight all the time because he wants to have sex and I do not want to have sex with him. So I quickly learned that either you leave both libidos low, which is fine, but you don't raise one or the other without raising them both, because you're going to set up conflict. So I quickly went out to do a mini fellowship with my mentor, amazing person, Dr. Erwin Goldstein out in San Diego, and went to some of the Ishwish courses, which you're familiar with, and started treating female sexual dysfunction back in 2009. And it really is a couple's disease. If you're treating one partner and you don't ask about the other, you're missing 50% of the boat here, you know? So I want to give you some great examples. Dr. Goldstein did a wonderful study many years ago giving men Levitra. And he gave men Levitra or placebo. And then he gave the female partners, and he never met them. He just gave the female partners at home a questionnaire called the FSFI, Female Sexual Function Index.
Sorry, I'm
And
just going to stop you for a second.
yeah,
Levitra is
it's
Viagra?
like a Viagra.
Okay.
It's like a Viagra. Yeah, it's called
Mhm.
let's just like a Viagra, same kind of concept.
Okay.
And what he found was in those men who he gave the Levitra to, they had an improvement in their erections. That makes sense. He gave them Levitra. Those men who gave placebo to, they had no real improvement in their erections. But the most fascinating thing was that in the women, the female partners at home, if the man got Levitra, that partner saw a significant increase in her libido, her arousal, her
Hers.
orgasmic function,
Wow.
significant. And in the men who got placebo, those partners didn't see any change or very little change at all. And that study really stuck with me because I said, look, this is a couple's disease. So many years after that, we did a study where we gave the women testosterone. I gave the IIEF, which is a sexual function questionnaire, to the men. Never wanted to meet them, just gave it to their male partners. And as you raise a woman's libido, his erections start to improve, right? And so you got to understand, I tell my residents, if you want to significantly improve the man's erections, don't forget about skyrocketing his partner's libido. It will really help. And we've done many other studies like that after radical prostatectomy, showing that again, you treat one, you're actually improving the other. Treat the other, you're actually improving the other. So focus on the couple because it's a couple's disease. It's not an individual disease, it's a couple's disease.
What are some other issues that male sexual dysfunction besides ED that might
Let's talk
impact?
about them because they're really important. The one that most people don't talk about is Peyronie's disease. Peyronie's disease is an abnormal curvature of the penis when it's erect. And if it curves greater than 60 degrees, it's prohibitive for intercourse. So, and it can cause pain to the patient and to the partner, right? So, and these patients are truly devastated because it's almost like a disfigurement. You know what I mean? Like if you know if it's completely changing the curve, and sometimes it can be multiple curves. And so 9%, up to 9% of all men in the world suffer from this. Can you imagine? Up to
Wow.
9%, but no one talks about it. I mean, it's a silent, it's one of those again, suffering in silence conditions. And in 2015, something very fortunate happened. The first FDA approved drug to treat this medication came out. And essentially, what it is, it's a medication that you place into the plaque that breaks up the rock. So, the best way to think about this disease is if I take a balloon and I put a piece of duct tape on the balloon and I blow the balloon up, what do you think is going to happen? It's going to curve in the direction of the tape because that's not expanding. So essentially, that's what it is. It's almost like a plaque, scar tissue sitting on the penile tissue. So we use a medication and we put the injection into the plaque, and this breaks up the scar. And so it improves the curvature by 30 to 40%. And so it's effective. There are other devices. There's a penile stretching device, believe it or not. These concepts actually came from the porn sites many, many years ago because they make the penis larger and wider, but they also make the penis straighter. And originally, you had to wear it for 6 to 8 hours a day, which is a lot of time. Now, the new ones, this is one out of Mayo Clinic, it's called Restorex. It bends the penis in the opposite direction, and you can wear it for 30 minutes twice a day with about 30% improvement in curvature. So those are some things that really help a lot. But Peyronie's disease is important. Many men suffer from it. They need to know there is treatment out there for Peyronie's disease. Another one we don't talk about is ejaculatory disorders. Everyone knows about premature ejaculation, but there's also delayed ejaculation or anorgasmia, not able to ejaculate at all. And we know that up to 30% of men suffer from ejaculatory disorders. That's a lot. And less than 9% will seek treatment. And so, premature ejaculation, if you think about it, it's if a man ejaculates less than 2 minutes and is bothered by the condition. So if he says I ejaculate in 30 seconds, but I don't really care, And I say, great, we're done. I mean, he has to be bothered
Right.
by the condition. But if he is bothered by the condition, the treatment options are pretty straightforward, and they're off label though. One is it's an anesthetic spray you can put on the penis. Most commonly used one is called Promescent. You can get online, but it numbs the penis, and so that the patient has decreased sensation, and so he can go longer. And those don't require a prescription. But most commonly are used the antidepressants, Paxil, Zoloft. They really work. But if you take it on demand, you got to take it 6 to 8 hours ahead of time, which is a long time. But if you
Right.
take it daily, then it's nice. But sometimes men don't want to take a daily antidepressant, so I have to kind of balance that. And then the off-label uses on second-line therapy for premature ejaculation are tramadol, but that's a pain medication, so some people can get addicted. But it does significantly delay the ejaculatory time. And then medications to help you urinate, like Flomax. You may have heard of these. They can delay as well. So those are some of the treatment options, and many men do not know that there are treatment options for this, but this one is absolutely treatable.
That's for premature. What about the opposite?
Delayed. So that one's a tougher one, because both in delayed and premature, you have to first figure out, is this lifelong or is this acquired? Did he have it ever since he remembered, or at 45 things switched over? But in delayed orgasmia, many times it's a psychological component. If they say if it takes me forever to achieve an orgasm with my wife, typically a delayed orgasmia is about 15 to 20 minutes. In America, the average ejaculatory time is about 7 to 9 minutes in men, just so you know. But this is a delayed, but really it's whatever bothers him. But sometimes men will say, with my partner, I cannot. It takes too long. But with masturbation, it's quite easy.
Right.
So then it's psychogenic, right? I mean, there's something going on. But so many options for this one. Again, all off label. But we use anything that increases dopamine in the brain. If you increase dopamine in men or women, you increase libido, and you can improve ejaculatory time. So it's going to be something like Wellbutrin, which you may be familiar with, Dosinex, which is a medication which increases dopamine in the brain. We use for pituitary tumors. Off-label, I use a medication called ADDY. We use it in men. It's called flibanserin,
Right.
and it raises dopamine and norepinephrine, and it helps with delayed orgasm. I want to give you a story because I just got this published 2 months ago. 28-year-old man came to me, very sad, and he has what we call primary lifelong anorgasmia. Never had an orgasm in his life. So we tried Wellbutrin, we tried sex therapy, we tried bremelanotide. These are all off label. We tried ADD, and he had his first orgasm in his life. And now, when he takes the medication, he can get about 50% at a time in orgasm. So anything that increases the dopamine will really help with orgasmic function.
So a lot of what you're talking about are treatments for women as well. So talk to me a little bit about the issues that you work with
Yes.
for female sexual dysfunction and treatment.
Men and women are not that different. I mean, they really aren't when you talk about libido centrally and hormone centrally. And so Addie came out in 2015, FDA approved, strictly increased her desire for sex. And there were many studies after 2015 in women showing that Addie actually improves orgasmic function. The other medications, for example, like Viagra in men, Viagra improves arousal. Does it help women? Of course it does. It helps improve arousal in women as well. Bremelanotide, which is a medication we use for women called Vyleesi, can help with orgasmic function and libido. Can it help in men? For sure it does. Again, it's used off-label, so we want to be very clear. But men and women are not that different. And you can use a medication in a man as long as you're counseling and it explains off-label in a woman and vice versa. And that's what we do. We use these medications interchangeably.
And what about testosterone for both men and women?
Great medication, and I think it's extremely effective for both men and women. The dose you want to remember for the women is 1/10 the dose. So whatever I use in a man, I want to use 1/10 in a woman. And I think it's very effective. Just in women, the key is to start low intentionally and then work your way up. If you overshoot a man accidentally, you can just bring it back down. But if you overshoot a woman, it's acne and facial hair, and so you really want to just go slow. So I prefer using injections in women, and it's subcutaneous. It's a tiny needle. She injects once a week. If she's willing to inject twice a week, it's even better because you don't get those big peaks and troughs. And I will use pellets in women. I use injectables in women. I use cream in women. In men, I have more options. I use the same, but I still like the injectables. But there are now orals. So a lot of men will take oral testosterone. We've never had an oral in the United States till 2019. Well, we did, but they would pass the liver and they could cause some damage. 2019 was our first oral called undecanoate that does not go through the liver, so very safe. And so, but most men like the injectables because it gives a good level and it's cheap. If you get it from a compounding pharmacy, it's $30 a month and they ship it to you and very, very affordable. They're very good for libido and erectile function, but there are other benefits with testosterone that are non-sexual. Let's talk about muscle mass, bone mineral density, fat deposition, sleep, some cognition. Really, it's not just about sex, it's about your overall health. And I'm not sure if you're aware, some major trials, some amazing trials came out called the Traverse trial that just came out last year. So I was involved in the Traverse trial. We started the study, first patient in 2018. Last patient was recruited in 2022. And we had the publication last year, the largest randomized placebo-controlled trial giving men testosterone strictly to look at, does it cause a heart attack? That was the number one primary goal. Good news, does not cause a heart attack. So that's great. We looked at sexual function. It helped with libido. Didn't help with erectile function as monotherapy, but it helped with libido. Urinary function did not cause any worsening of urinary function and did not cause any worsening of prostate cancer or cause any prostate cancer. So if anyone on this podcast is listening to this, look up the Traverse trial. It's amazing. A lot of good data on that study.
Now, how do you get that study for women? Because they don't study it on, especially postmenopausal women.
Yeah, that's very true. But your point's well taken. We don't have a large studies in women on testosterone, right? It's not FDA approved in the United States. So if I went to Walgreens and said, please give me the testosterone for women, that doesn't exist, right? If I went into Europe, they used to have Intrinsa as a patch. Other places have testosterone, but the US still to this day, unfortunately, surprisingly, does not have any FDA approved testosterone for women.
Because they don't study it on women. The men get the funding. We need the funding for women
that's point.
as well.
We get some studies, but you're right, not to this magnitude. You are absolutely correct.
Yeah. I know I asked you about this when we first met. There's controversy over delivery systems of testosterone for women, the pellets and the injectables. Some doctors are adamant that I actually have heard the word malpractice.
Yeah.
I have personally, I get the pellet. I've been getting it for years now. So I'm just curious as to your opinion and why another medical provider might have it.
So two things, testosterone is a compound, it's a molecule. So it's these different formulations are different ways to get the testosterone into the body. One is not more magical than the other. We've been treating many women on testosterone pellets since 2008 when we had Testapel, then we switched them over to compounded testosterone pellets. And physiologically it's fine, but it causes a large surge at the beginning, and then it kind of comes down towards the end. And towards the end, these women don't feel they're optimal, and then they're kind of rushing back in to get their next pellet. And so, but if you use an injectable or a cream, you tend to not get those long, big peaks and troughs over a big period of time. The injectable can have a half-life of about 7 days. So over a course of 4 weeks, you'll kind of get a nice baseline with little peaks and troughs. So my favorite really is the injectables. I'll use creams secondarily, but they really don't absorb very well. The creams are dependent on skin penetration. So if it penetrates your skin, great. If it doesn't, it doesn't. And you can get variable penetration day by day, so that can change as well. So truthfully, my favorite would be the injectables, but I would go to pellets second, in the sense that, it's convenient. It does work. It does get the levels up. You just got to be careful because you can't take the pellet out. So if they don't like it, it's a little bit tricky.
So there's as far as there's no excessive dangers in having even the injectables, the levels of testosterone, as long as they're
The studies have
calibrated
shown,
properly.
long-term studies have not shown increased danger with testosterone in general. Some studies have shown that testosterone may be protective against breast cancer. I don't know if you saw that data. So it could be. The only problem I have with the pellets is I don't like that long super physiologic run at the beginning. It takes them pretty high, and I try to keep it more in the sweet zone if I can. So, but I have patients since 2008 that have come every 3 months to this day and will not stop coming because they feel so good on the pellets. And we just presented a major abstract at a scientific meeting with my pellet data and all the women that I've treated over the years. And one interesting thing that we just submitted this for publication is that in women, even though they're at super physiologic levels, we don't see the high erythrocytosis rates that we see in men, which is kind of odd. And I don't
What
know
does that
why.
mean? Sorry.
I'm sorry, elevation in the red blood cell count.
Okay.
Like, in men, many times I have to have them donate blood and keep donating blood to bring their blood count down because the pellets can raise their blood cells. But
Mhm.
in women, I'm not seeing that. And so that's just an interesting finding.
So as far as you're concerned, whichever form you do, it's just the issue of the spike, and that's why you like the injectables.
I like the injectables better. Now, don't get me wrong, injectables have some spike also, but they're milder spikes.
Right.
If you dose it and split it twice a week, then the big spike that you see all of a sudden. So it just depends on how you want to do it. But I think the injectables, anything that doesn't spike too much, I think is better. Now, but some women really like the pellets. They just say they feel better because when you take a woman from low to high in a big delta, that delta feels like a rush. They feel good when they get their pellets initially, you know? And so many women like that. But I have not seen any adverse events since 2008 in the women we treated. Maybe some women have to donate blood. Other than that, it's been very well tolerated.
As I understand it, actually, now that I've been on it for so long, that the level isn't quite that low that there's as much of a spike. Does that make sense? Or,
Well, a
I mean, it
couple
does go
things.
down, but not
It
quite
does go
as.
down, but it's just very simple. It's so Karen, it depends on when I catch you. So if I give you the pill today and your levels go up and then they start coming down, wherever I put the next pellet will dictate where your level is, right? If I wait 3 months, it may be at one number. If I wait 4 months, it's another number. If I wait 5 months, it's another number. So the
Right.
trick is to catch her before she falls too low. You know what I mean? But don't don't put it when she's too high either, because it's going to cause a problem. So you find the sweet spot. Now, what's nice is, and they've shown this in men as well, is that a woman will typically have about the same decay curve every time. So if she's a 3 monther, she's a 3 monther. If she's a 4 monther, she's a 4 monther. You can figure out the pattern, and you'll just stick to that pattern with her.
Is there any disadvantage or counterindication to switching from pellet to shots or shots to pellets or?
No, great question. So I say, look, there's three things you want to remember. It's cost, compliance, and concentration, and actually convenience. So everyone's different. So say this is not a cost is not a big issue to me. Convenience is really important. I'm terrible in putting my daily cream, so that person would do great on a pellet. If someone says I'm great at compliance, I would say so. And then convenience. So if it's cost, compliance, concentration, convenience, maybe I'm using a cream, but I can't get the level. So I take all four into account. It doesn't matter which one. Whatever works best for you on the four C's is what we
Right,
go with.
right. You mentioned earlier, and I know this is not your necessarily your area of expertise, but I'm sure that you're familiar with that some often for certain issues, you send your patients to sex therapy. Do you
Yes.
know what exactly, like how they help? Of course, everyone imagines a sex therapist is going to
Yeah.
be on the couch with you, but I
Yeah.
don't
Yeah.
think that's what's going
They've been
on.
so helpful because I'll tell you this, when COVID happened, a lot of my sex therapists started going virtual. And I found very quickly that the male patients actually much rather do virtual than in person. And that was a barrier. So they don't mind jumping on Zoom if they're going to do it, but they rather do that than go in person. So that's number one. Number two is that, but most men just don't want to go see a sex therapist for some. It's just kind of like pushing them to do it. They just really prefer not to. But those that do see a sex therapist have the best outcome because sex therapy in conjunction with medications is much more powerful than each one by themselves, you know? And I tell them the sex therapist is a cure for your premature ejaculation. So you can take an antidepressant and you take it for the rest of your life, or you see a sex therapist and they'll teach you the start stop technique. They'll teach you the squeeze technique. They'll walk you through it. And that's a cure. And unfortunately, most men just say, "Give me the pill." They say that. But I say if you can do both, you may be able to get off the pill, and then you're fine. So very effective for erectile dysfunction, particularly psychogenic ED. A lot of young men, 30s, 25, they don't usually have organic ED. They have a new girlfriend, they have a new relationship, and something called a vicious cycle occurs. This is the vicious cycle. So Karen, I got a young man engaged in sexual activity, and he gets ED. Okay. He's so freaked out that he's 29 years old. How could a 29-year-old have ED? That the next time he has sex, he is saying to himself, I hope I don't get ED. And the second he says that, it's a guarantee he's going to get ED, right? It's a guarantee. Now it's happened twice. So now the snowball gets bigger. It's like, oh my God, it happened twice. And then the next time he's thinking about it, and it keeps on happening. And so you have to break that cycle. And so daily Cialis has been very helpful in breaking that cycle because they take it every day and things look like they're normal. But sex therapy is extremely helpful in that situation where you have psychogenic ED.
I mean, it makes sense. It's the same with any kind of therapy, you know, if you, any kind of antidepressant alone, it's not necessarily going to cure you. You'll feel better every day, but it's not necessarily going to make the problems, you know,
Go
better.
away. That's
Yeah.
right. So
Yeah.
I tell them if you want the cure, sex therapy.
Do you see porn being an issue?
It can be. So porn can, in my practice, can see two things. One is that it can lead to erectile dysfunction and it could lead to delayed orgasmia. Because what happens is when a man's continuously watching porn, his expectation goes up. Okay. And when he's engaging in sexual activity, his reality is not meeting his expectation. And so it takes much longer to ejaculate. He may lose his erection. And so it's an issue. And so if someone comes in and says, I've delayed orgasm or anorgasmia, or I'm starting to develop erectile dysfunction and he's young, I say, are you watching porn? You know, because you have to put that in the game.
It's interesting because women often, I mean, we go to the gynecologist theoretically from when we're, you know, we get our period. I don't know. So hopefully
Yeah.
as soon as that, but if not, when we get to college, we start having regular medical care, where men tend to wait for some catastrophe. And I saw it with my ex-husband. I remember we had some incident where he passed out and he ended up having to go for a full cardiac workup, and it was, everything was fine, but that was the first time he really started going to a doctor, and he was probably 50.
Yeah.
So how do we get men to start seeing a doctor regularly?
Yeah.
It's just as important as we go to the
I
gynecologist.
can't tell you how important it is. And I call it the area under the curve because let's say you start with a disease or some process is going on when you're 30 and you continue to let it grow and grow and grow till it manifests. All that damage, let's say hypertension or increased blood sugar, is causing damage and irreversible damage in some cases to your blood vessels. So the sooner you act, the less likely you are to start rising that slope, right? And so I have always believed that if you, there's two ways to look at this. We call it offense and defense. Okay. Offense essentially means diet, exercise, sleep, and stress reduction. There's not a pill on the planet stronger than diet, exercise, sleep, and stress reduction. And if you decide, Karen, that you're going to focus on one of them today, you decide on sleep or exercise, and you're going to go hard on it, it's going to change your life. It's going to make a huge impact on your quality of life. And it's not only going to feel better, but you're preventing problems from happening in the future. You're preventing problems from happening in the future. Defense means I want to make sure that nothing bad's going on. So cancer screening to make sure there's no issues. We can talk about that. The cardiovascular screening, that's another way. So there's only 4 ways you're going to die. It's going to be cancer, cardiovascular, metabolic, or neurodegenerative, means Alzheimer's, barring that you don't get in a car accident or a plane crash or anything. Those are the 4 ways. So if you knew those were the 4 ways that something bad is going to happen to you, why not be proactive about making sure that none of those 4 are going to get you? And so we have the patients come in and be proactive about screening. And those are very, very important. So 2 ways to look at it. But as I mentioned earlier, how can I get men to take their health seriously? And blood pressure is not going to do it. Erectile dysfunction will.
One thing.
It will. It is actually my gateway to get them to start taking care of themselves. That is my gateway.
And that if they come in young, but when they're 65 and they haven't
Right.
seen a doctor until then, that's really unfortunate.
It's unfortunate. And I always say it's never too late to start. It's never too late to start because if you start at 65 I can make it to 90, I got 25 years to, just make it really good for you. And I want to improve not your lifespan, but your health span. I want the quality of life to be good as well. And that's why we go pretty hard. If the patient comes in, I say, look, this is a partnership. I'm happy to fine tune your hormones. I will fine tune your medical health. But that's 50% of the story. You got to meet me on the other 50%. And if you meet me on the other 50%, we're on fire. We will be on fire, but you got to meet me on the diet, exercise, sleep, and stress.
Yeah. You mentioned cancer. For women, this is not necessarily a cancer prevention, but I've heard, and unfortunately, sometimes this is the only advice women get, is use it or lose it. That if you don't continue to maintain blood flow to the vulvovaginal area, you're going to get what they used to call atrophy, and they've rebranded. But anyway, you're going to have more issues. I've read that with men, it's important for prevention of prostate cancer. Is that in fact true, or
Not
that's just a
exactly,
story?
not exactly. Yeah. So, I mean, some have said, if I have more sex, will I have decreased prostate cancer? There may be an association between men who have more sex and that they have less prostate cancer, but it's not a causality. Like it could be, it may be an association, but it's not that if I have more sex, I'm going to decrease my risk of prostate. I have not seen convincing data for me to believe that. There are other things that you can do. I mean, the best part of cancer prevention for prostate cancer is screening. Screen. And we now have very sophisticated tests. So the PSA is a bad test. It has very poor sensitivity, specificity, but we came out with even better tests. So we now have a 4K or a Phi score, which gives you another idea if the PSA is real or not. And now we have MRI, which is even better than those two. So in the old days, I'd get a PSA, it was elevated, I'd have to do a biopsy. Now I can use my tools with the Phi, the 4K, other genomic markers, and then I can also get an MRI. And if the MRI shows something, then I can put this into a machine that actually superimposes the image with the ultrasound, and I can do a targeted biopsy. If you saw me when I first came out of my residency, I didn't have that. So we would do 6 random biopsies on one side, 6 on the other, and we'd hope that we'd get it. But now with a fusion biopsy, we can hit it to the millimeter. We know where the lesion is. And so the MRI has really revolutionized the way we diagnose and treat men for prostate cancer.
Should the MRI for men be like the mammogram is for women, that everyone should have an annual?
Yeah, then you come into like, cost and benefit ratio. So essentially using the PSA and the Phi or the 4K as a marker to decide who needs the MRI makes the most sense. And if your PSA is going up or your Phi score or 4K is going up, that would be ultimately the best. Because we have, unlike in women for a blood test, we have a blood test for men. It's not the best, but it's pretty good in terms of the Phi and the 4K and using it in combination. So when you put them all together, it increases the sensitivity and specificity. So I think we're still on the blood test first, and if we need to go to MRI, we do, but I wouldn't advocate MRIs for everybody.
And what age should men start to be screening more?
Unless you're high risk, which is African American or have a family history, it's 55 to 70. Every year, 55 to 70, you should be screened. Now, we call this shared decision making. Some men with counseling may say, I want to do it every other year. Some men may say that, based on my medical condition, I don't want to do it anymore. So we start at 55, but we start with something called shared decision making, meaning, is it worth it to do this every year in the patient?
Is there anything we haven't covered that you want to talk about? And then I want to ask your top 3 things that you would tell men to say.
Yeah, I always like to say that this is sexual dysfunction in men and in women. We all suffer in silence, and you don't have to suffer in silence. And you know that, Karen. There are so many great treatments out there. You just have to go out and seek those treatments. If you can't get those treatments, now we have the internet, and we have, you can get information online. There's so many websites. There's the smsna.org, which is Sexual Medicine Society of North America.org. Phenomenal website, lots of resources on all the conditions we talked about today. So I think that's just another option, but don't have to suffer in silence. There are treatment options available, and just go out and seek them.
I will put a link to that in the show notes. Thank you so much. This was, wow, totally
My pleasure.
insightful, a ton of information, and I really, really appreciate your time. And
Thank you. No problem. Thank you, Karen.
Thank you.